Alrighty, welcome everyone to our diabetes and podiatry lecture today. First of all, just want to start off by acknowledging the climate that we're in. I'm sure that everyone has a big mix of emotions right now as we wait the final results for the election. So just acknowledging that we have those feelings with us, and we're going to go ahead and keep them with us throughout this lecture. Welcome to the Diabetes and Podiatry lecture. Thank you for those of you who have found your way, whether you've joined on YouTube or if you're joining in over the phone. Before we get started with the diabetes piece of the lecture, we're going to start off by learning more about the pointer study. So at this point, I'm going to go ahead and hand it off to the pointer study team.
Great. One second. Can you all see it?
Yes.
Okay. So I'm Shartae Robinson, the program manager here at Rush for the ITM, and I also serve as the grassroots recruitment specialist for the pointer study. So I will hand this over to our team that's inclusive of our PIs, the project director, and then also an interventionist, a part of the pointer team who will be sharing a presentation about the U.S. pointer study. Dr. Tangi, Dr. Gittleman.
Hi, good afternoon. Dr. Tangi, should I get started?
You're muted, Dr. T.
I will do that. She gave me the hand sign. Well, good afternoon, everyone. Of course, we are all still concerned about the election, but I'm sure all of us are also concerned about our brain health. And in fact, that's one of the biggest concerns that people have as they age. How many of you, and of course I can't see you, but how many of you know someone with memory loss, dementia, or Alzheimer's disease? Well, if people listening are a typical audience, almost every hand will go up. And of course, if I said, how many of you have provided care for someone with memory loss, dementia, or Alzheimer's disease, probably an equal number of hands in the audience. So many of us have been and continue to be affected by these conditions, either directly or by caring for a loved one with the condition. First, a few quick definitions before we start. When I say memory loss, understand that I am not talking about normal forgetfulness, like forgetting where you might have put your keys occasionally, but really I'm talking about something more severe, something that not just forgetting the keys occasionally, but maybe forgetting the keys where you put them several times a day, or even forgetting what keys are actually for. Does that make sense? And when I say dementia or Alzheimer's disease and memory loss, there's a difference between those. Memory loss is a symptom. Dementia is a broad group of conditions that are often connected not just to memory loss, but can include impaired judgment, memory loss, problems with spatial perception, and so on. And Alzheimer's disease is a particular cause of dementia. I also want you to understand again that memory loss is not a normal part of aging. Aging is not the disease. We all get some memory loss as we get older, but none of us should expect that the memory loss should impact us and impair us in our daily lives. Next slide. So the US pointer is a study about this big issue, the health of our brains. The study wants to examine how best to protect our brain health for the future. US Pointer is what is known as a clinical trial. Clinical trials are how we learn about effective ways to address health issues. The medicine on the shelves at any pharmacy you might go into got there because of clinical trials, because that medicine was shown to be safe and effective. So clinical trials show how to treat various health conditions. Well, we can also do clinical trials of other factors and not just medicines. So a clinical trial is a research study to see if a certain treatment, in this case, the treatment might be diet and exercise and so on, is safe and effective in the health of participants and makes a difference to their health for various conditions. Of course, while the trial is very important, and we always prioritize the health of our participants and the safety of participants, and people can withdraw from clinical trials at any time. Next slide.
So I think I will come on now, and I'd like to share with you the purpose of the U.S. Pointer Brain Health Study. Thank you, Dr. Gittleman. My name is Dr. Tangney, and at Rush, I am the principal investigator, and I'm very thrilled to be involved in this trial because it's designed to test whether two different healthy lifestyle programs that encourage exercise, a healthy diet, and mental and social activities can protect the brain among us all as we age over time. And I think one of the most important things about this trial is that if we are able to enroll a very diverse group of participants from all of our communities, because science needs to represent all of us, and if we see positive results, we think that participants have made a tremendous contribution to developing a program that can work for all of us in our communities. It's a program that is very much like other programs that have existed that first started as a clinical trial and then have been used in clinical practice and community centers all over. Next slide, please. So a little bit more about the specifics of this landmark study. It occurs in 5 different locations across the United States. North Carolina, Chicagoland, my partner and advocate and Rush, we're working together to represent Chicagoland, Houston, New England, Rhode Island, and Northern California. Each one of these 5 major sites is responsible or tries to recruit nearly 400 participants. And when they are enrolled, if they meet our criteria, participants will be randomly assigned. That means simply like a flip of a coin, they can be assigned to one of 2 possible lifestyle groups. One is a structured lifestyle group, and the second is self-guided. And what that will, as a result of that, we will follow these individuals, providing and updating them with regard to their health for the next 2 years. Next slide, please. And I believe my colleague is going to jump in right now.
Hi, everyone. My name is Sarah Grafe, and by license, I'm a chiropractor and registered dietitian. However, on Pointer, I am an interventionist manager, and this is such a passion of mine to be able to be involved in a true lifestyle change study. Having said that, we do want to recruit participants who have room to improve their lifestyle. So we are looking for participants who have cardiometabolic risk factors or family history risk factors. We are looking for participants who are not regular exercisers, which probably isn't too hard to find. And we also are looking for participants that are older adults, ages 60 to 79 years old. And can you go to the next slide, please, Charte? Thanks. There are benefits to joining the study. We have regular health coaching and truly trying to initiate behavior change using motivational interviewing, as well as talking about certain specific criteria related to diet, exercise, brain health, and health monitoring. There are also clinic visits that are delivered periodically, and participants can get the results. They can also get the results sent to their physician. There's periodic check-ins over the 2-year study. At the end of the study, there's also a review of their progress. And Charte, the next slide, please. So as we mentioned, there's health monitoring that's a part of the actual intervention. We do have team meetings, and right now I'm sure people are still concerned about COVID, of course. So we do have a hybrid possibility where some people could be virtual, some people could be in person. However, currently we are all virtual. So that's really important to participants, and it might be really nice for those who feel like they're a little bit stuck indoors. This is something they can currently do from their home in a safe environment. Ideally, we're going to have in-person team meetings again, but that's currently on hold. Of course, it's no cost for them to join, and there are also incentives that are given to the participants depending on which arm the study they're in. They'll get slightly different incentives. Okay, next slide. All right.
My name's Mira Soder, and I'm the project manager for the Pointer study over at Rush. My colleague Evelyn Torres couldn't join us today, so I'll be speaking on her behalf. But I just wanted to talk about how unique the US Pointer study is. It really isn't like your typical clinical trial. It's driven by community members, and it's located in the communities to be accessible and convenient for all participants to join. It's not a pill or a drug that you see when you think about traditional clinical trials. A healthy lifestyle is the prescription. As of now, we don't have any drugs that can prevent or treat Alzheimer's dementia. And in order to be proactive about our health and our brain health, this study can hopefully yield results to disseminate to older adults and younger adults who want to take care of their brain health long term. We're committed to positive community benefits long after the trial is over. The methods that we'll use to engage study participants in adopting a healthy lifestyle are meant to be sustainable beyond the 2 years that they're in the study. If you're going to join a study for brain health, for figuring out a way to make a real difference in the health of our communities and future generations, this is the one you want to join. Next slide, please. As Dr. Taney had mentioned, this is a multi-site trial, which means there's cities all across the US that are doing the same exact study. And so here in Chicago, we're looking to recruit older adults who are interested in participating. Next slide, please. Let's talk action. What does the US Pointer study need to be successful? First, consider joining. We'd love to have you. There's certain eligibility criteria beyond what Sarah had mentioned, but if you're here for the diabetes and podiatry talk and you want to join as a member, just reach out. You can do so either at Rush or Advocate at 708-660-6463 and an Advocate at 847-720-6467. If you prefer to email us, that's fine too, either at pointer@rush.edu or lgh-uspointer@advocatehealth.com. If maybe this study isn't a good fit for you, consider other people in your life, maybe your partner or a sibling or your next door neighbor to join the study. Help us to spread the word. We're looking for neighborhood locations for our team meetings as well. So perhaps one way to help us spread the word about the Pointer study is if you're plugged into your community about spaces, that might be a good place for us to set up shop. Although under the current circumstances of the COVID-19 pandemic, we're delivering this study virtually, but when it's safe to do so, we'd much rather be face-to-face so we can deliver our intervention and health coaching in person. We also want to know how we can help your community. So if you have any ideas, we're definitely open to it. The big takeaway here is that we can all get involved in making the Pointer trial successful, even if you're not eligible or don't want to enroll. This study is a landmark study that can improve health and potentially protect against memory loss and dementia for all people. Thank you.
Jasmine, that's the end of our presentation.
Awesome.
Is it an opportunity to ask questions, or do people type in their questions, or do we have time for that? We want to be respectful of the time for the other presenters as well.
Yeah, typically there is a lag for questions, but is there a way? Well, at the end of the lecture, and for those of you who are joining in over the phone, thank you so much for listening. And for those of you online as well, if you have any questions about the pointer study, you can type them in the chat box. And at the end, we'll have a Q&A and you can let me know your questions as well. And then I can go ahead and get those answers from the pointer study team. And at the end of the lecture, we're also going to have this slide up again with the information on how you can sign up for the study. But thank you so much to the Pointer Study team. We really appreciate you being here. And thank you to all of our participants who have joined and heard about it.
Thank
And
you.
right,
Thank you.
yes, yeah.
Thank you.
Thank you.
And for the participants as well, I really encourage you to give it some serious thought. We will be sending out a video where you can learn more about it. And again, at the end of the lecture, we're going to give you some more information on how you can sign up and how you can learn more. And right now, we're going to go ahead and switch gears back to the diabetes lecture. And so we're going to get started here. For those of you who have joined on YouTube, throughout the lecture, you can type in your questions in the chat box. So if you've joined in on a computer, you'll see the chat box right on the right side, just like it's displayed here. And if you've joined on a tablet or on a phone, but you're viewing it on YouTube, you'll see it at the bottom of the lecture. So wherever it is for you, if you have any questions, please do type them into the chat box and we'll share it with our speaker at the end of the lecture. And for those of you who have joined over the phone, we'll also give you an opportunity to unmute yourself and ask questions at the end of the lecture. And so right now we're very happy to welcome our speaker, Dr. Christine Zachariah. And so we're gonna go ahead and introduce her before we get started. So Dr. Zachariah was born and raised in the Chicago area. In her spare time, she enjoys playing tennis and cycling. She received her medical degree from New York Medical College, did her residency training at Rush in internal medicine, and went on to Brown to do her fellowship in endocrinology. Following the completion of her training, she practiced out of North Shore University Health System as an endocrinologist for 3 years prior to returning to Rush in 2017. So we give Dr. Zachariah a very warm welcome, and we're going to go ahead and get started with the diabetes and podiatry portion of the lecture.
Nice to meet everybody today. So I'm just going to go ahead and share my screen. Give me a second here. Okay, so hopefully you're all able to see this clearly. So as you heard, today I'm going to be talking to you about diabetes. I'm currently an endocrinologist here at Rush University Medical Center. So to give you an overview, first I'm going to talk about the definition of diabetes as well as the associated symptoms with this condition. Then I'm going to go through how to diagnose diabetes, as well as talk about the different types of diabetes. Then I'll review the ABCs of diabetes, which will get A1C, blood pressure, and cholesterol. And then I'll talk about ways to monitor your blood sugars with the current available technology. So that includes looking at things like using a glucose meter versus a continuous glucose monitor. Then I'll talk briefly about diet and lifestyle. Then I'll go over the medications that are available for diabetics in general. And then I'll talk about the various complications of diabetes and what you can do to monitor for them. And then I'll end the talk by talking about diabetes day to day, especially with the COVID-19 pandemic. Then I'll talk about travel as well as emotional health related to diabetes. And then there'll be plenty of time for questions at the end. So what exactly is diabetes? So diabetes is a chronic disease that affects how your body uses blood sugar. So food is broken down into a sugar product known as glucose, which is released into the bloodstream. Normally, when sugar levels increase in the body, the pancreas releases a hormone known as insulin to bring it down. And specifically, insulin is responsible for bringing glucose into different body cells for both nutrition and energy. So depending on the type of diabetes you have, either your body isn't producing enough insulin or is unable to use the insulin well. This results in the glucose lingering around in the bloodstream, slowly damaging small and large blood vessels throughout the body if it's left in a high state for a prolonged period of time. Over time, these uncontrolled sugar levels can lead to irreversible damage in multiple body organs. So the common symptoms of diabetes include increased thirst, increased urination, increased hunger. Patients will experience symptoms of fatigue, unexplained weight loss, as well as blurry vision. Patients will notice mood changes, and they're susceptible for frequent infections, including UTIs, yeast infections, gum infections. Patients with diabetes also have poor wound healing, which leads to open sores and wounds that take a long time to close up. So in terms of statistics, more than 34 million people in the US have diabetes, and actually more than 88 million US adults have prediabetes. And at the present moment, diabetes is the 7th leading cause of death in the United States. And the medical costs for people with diabetes are twice as high when compared to people who don't have diabetes. So when coming down to how to diagnose diabetes, there are several parameters we look at. One includes the fasting blood sugar level. So for diabetes, if the fasting blood sugar level is above 126, that's diagnostic of the condition. If it's between 100 and 125, that's consistent with prediabetes. An oral glucose tolerance test is another way we check for diabetes, less commonly used. We usually do this for pregnant women who were screening for gestational diabetes. But if an oral glucose tolerance test is performed by your doctor, basically a 2-hour post-glucose measurement of greater than 200 is consistent with diabetes. Anything between 140 and 199 is prediabetes. And A1C is a common screening test that a lot of physicians will use. If you find out that your A1C is 6.5 or higher, that's consistent with diabetes. If it's between 5.7 and 6.4, that's consistent with prediabetes. And basically an A1C just tells you and gives you an idea of how sugar-coated your blood cells are. And the reason why doctors measure this only every 3 months is because our blood cells turn over in our bodies every 3 months. So to check your A1C month to month, you're not going to see a significant change. You have to wait a full 3 months before you recheck it. So now I'm going to talk about the different types of diabetes. So type 2 diabetes is the most common cause of, or common type of diabetes in the United States. It accounts for 90 to 95% of cases. In this situation, insulin in the body does not work well due to insulin resistance. But over time, these patients can also become insulin deficient due to pancreas burnout. And you'll see this in the later stages of type 2 diabetes. Type 1 diabetes accounts for 5 to 10% of cases in the US. And this is due to an autoimmune disease that attacks the body's insulin-producing cells in the pancreas. And as a result, patients are unable to make insulin. Prediabetes is basically the precursor to type 2 diabetes. And then gestational diabetes is due to insulin resistance in pregnant women due to the release of placental hormone known as lactogen. And these patients are actually at increased risk for type 2 diabetes later in their life. So to go into more detail about type 2 diabetes, this usually occurs in overweight to obese individuals. It occurs in patients who usually have a strong family history of diabetes. It can also be a result of physical inactivity or poor diet. And the mechanism by which people develop type 2 diabetes is through insulin resistance. And so insulin resistance happens due to the release of inflammatory markers from adipose tissue in the body. And this in turn interferes with the body's ability to actually respond to the insulin. In type 1 diabetes, we have 2 overall classifications for this. It generally happens in younger individuals. If it happens during childhood, it's known as juvenile type 1 diabetes. If it happens in early adulthood, specifically in the ages of 20 to late 30s, that's known as latent autoimmune diabetes in adulthood, or LADA for short. And oftentimes patients may be mislabeled as being type 2 diabetics when in fact there are actually LADA patients. And so when I see these patients in the office and I notice they don't have the traditional risk factors for type 2 diabetes, such as obesity, strong family history, or they just have unexplained increasing sugar levels over time, I'll often screen them for this condition. So in this form of type 1 diabetes, basically the patient's immune system produces antibodies that kill off the insulin producing cells of the pancreas, causing them to become insulin deficient. So now I'm going to go into the ABCs of diabetes. So A stands for A1C, and the A1C goal for each patient is dependent on what the doctor views it should be based on age or other risk factors. So an A1C goal of less than 6.5 is appropriate for people who are newly diagnosed and for individuals who are under the age of 70. This A1C value of 6.5 translates roughly to a blood sugar level in the 120 to 130s range. A goal A1C of less than 7 is appropriate for patients who have poor kidney function or have had diabetes for a long period of time. That translates to a sugar level of around 140 to 150. A goal A1C of 7 to 8 is appropriate for our elderly patients or patients who are just susceptible to having low sugars in general. And the reason why the A1C goal is looser for the elderly population is because the low sugars are far more dangerous than the high sugars at that stage in their life. And so a goal A1C of 7 to 8 basically translates to an average blood sugar in the 150s to 180s range. So going to letter B, B stands for blood pressure. The goal blood pressure for our diabetics is under 140 over 90. If you're following with a cardiologist, however, and you have a lot of pre-existing cardiac conditions, they may have a different blood pressure target for you. But for the majority of our diabetics, a systolic blood pressure of less than 140 over a diastolic pressure of 90 is appropriate. C refers to cholesterol. So specifically within the cholesterol parameters, we're looking at the LDL, which is a bad cholesterol. A goal LDL is under 100 if the patients don't have any cardiac history, and it's under 70 if patients do have a history of heart attacks or strokes in the past. In general, the American Heart Association recommends that all diabetics should be on a statin as long as they can tolerate it, independent of the cholesterol levels. And the reason for that is thought that there is an anti-inflammatory benefit to statins, which helps reduce the risk of heart attacks and strokes over time. So even if patients have a normal cholesterol, you'll find that the doctors will start patients on statins to help protect them against this cardiovascular risk. So now I'm going to talk about ways to monitor your diabetes. So essentially, a common way that's available for the majority of our patients is to use a glucose meter. So depending on the physician's instructions, you may be instructed to check anywhere from 1 to up to 4 times a day, sometimes more if you're having frequent hypo or hyperglycemia. And I'll talk about that a little bit later in the talk. But essentially, the target blood sugar is going to depend on really what your A1C target is. So as I mentioned earlier, an A1C target of 6.5 is going to indicate titer control, and that translates to a fasting blood sugar less than 120 and a pre-meal blood sugar less than 130 and a bedtime blood sugar less than 140. And so this bedtime parameter is going to change depending on how soon after dinner you're checking the sugar measurement. But traditionally, if bedtime's a couple of hours after dinner, then less than 140 would be an appropriate target. But if bedtime is 4 hours later, less than 130 or less than 120 even would be an appropriate target. For patients who have an A1C target of around 7 or even 8, the fasting target for the sugar should be under 140 and before meals less than 150. And then bedtime would be around 160. So again, your doctor will give you these specific goals depending on what your specific A1C target is. So when you're checking your blood sugar, it's always important to wash your hands thoroughly and have clean hands. The big reason for that is because if you do have grime on your fingertips, that can actually falsely elevate the sugars that are being measured. The other reason is just to prevent or reduce your risk of getting infection from repeated finger sticks on dirty fingertips. Another tip is to just poke the sides of the fingers, not the tips or the pad. We have more nerve endings in the pad and the tips, and so if you poke on the sides, it's going to be a little bit less painful that way. Also, if you have poor circulation in your fingertips, it's a good idea to just milk the fingers to get the blood flowing, or you can just use a warm compress on the fingertips, and that will help dilate the blood vessels in the fingertips to get a good finger stick. So there's a lot of meters that are out there on the market, and honestly, they're all comparable in accuracy. So the doctor is going to prescribe what's covered by the insurance. If at any point there's a lapse in your insurance or a lack of coverage in general, Walmart offers a really cheap meter, the Rely On meter, which is reliable, and it's very affordable. So you can actually get this meter over the counter for $9, and the strips, about 50 strips, will cost you also $9. So this is a good emergency resource in the event that the insurance isn't covering your meter for whatever reason. So a newer technology that's been on the market for a while, but it's really gotten more advanced and more reliable, is the continuous glucose monitor. So the continuous glucose monitor measures your sugars throughout the day through insertion of a catheter into the skin, specifically in the lower layer of the skin. And this is something you can self-apply either on the back of your arm or on your abdomen. And it's something that you can change out by yourself every 10 to 14 days, depending on the sensor brand. So with the new changes in this technology, this has become as reliable as a finger stick, whereas about 5 or 10 years ago, this sort of technology was just more a guide to tell patients, okay, your sugars are going high or low, but it was not as accurate back then as a finger stick. So the one that you've probably all seen on TV by now is the DEXCOM G6 sensor. This is personally one of my favorite sensors for diabetics if it's covered by the insurance, simply because it's very reliable, it's easy to use, and it is very sensitive at picking up high or low blood sugars. And so this technology is compatible with iPhones or most Android phones. And if you have an Apple Watch or a smartwatch in general, you can actually see your sugar tracing in real time throughout the day. The other sensor that's out on the market is the Freestyle Libre. So they had a 10-day Libre before, and now they have the 14-day professional Libre. This one also will measure your sugars throughout the day, but you actually have to scan the sensor device throughout the day in order to get a trend. So if you just carry the transmitter with you or the reader with you, but you're not scanning throughout the day, you can actually have gaps in sugar data. And so this is the reason why I'm not quick to jump to prescribe this, but again, this is still a better option than doing finger sticks because you'll get more data with this technology. So the benefits of the CGM are basically to warn patients of impending low or high sugars. It gives patients the ability to trend their sugars throughout the day. And honestly, I found that it's given good feedback for patients on their lifestyle. So they'll see actually what foods will trigger their sugars to go really high or maybe even really low. And oftentimes, if they're looking at their sugars following exercise, they'll see the positive reinforcement of how exercise brings down the readings. So now I'm going to break down what's considered a low versus a high blood sugar. So high blood sugars are formally referred to as hyperglycemia, and this basically refers to a sugar that's higher than the target that's been set forth by your physician. So if the sugars are really high, meaning they're running 200, 300s, or even higher, patients will often have increased thirst, increased urination, blurred vision, and fatigue. Low blood sugars, formerly known as hypoglycemia, refers to a blood sugar less than 70, and patients with sugars that are low will typically feel shaky, sweaty, dizzy, or confused. So if patients actually have repeated low blood sugars over time, they can actually lose this sense of what we call hypoglycemic awareness, and that can be dangerous. And so this is an instance where having a continuous glucose monitor is really helpful because it'll actually warn you when your sugars are starting to go down. So with regards to treatment, specifically with hypoglycemia, it's important to treat a blood sugar less than 70 with 15 grams of carbs. So 15 grams of carbs includes 4 glucose tablets, half a glass of juice, or 1 tablespoon of sugar, syrup, or honey, or 4 ounces of regular soda and not diet soda. And so we follow the rule of 15s, where you basically take in 15 grams of carbs, and then you retest your blood sugar 15 minutes later. And essentially you repeat this treatment until your blood sugar starts to come up above 70. However, if you know that after treating your low blood sugar that you're not going to eat for a while, it's important to have a small snack to maintain those levels. And let's say you're in an emergency situation where you're actually passed out and your family or your friends that are with you are not able to give you those mentioned glucose therapies. Glucagon is an injection that someone can actually administer to you to basically tell your liver to put out sugar instead. And so it's important, if you are someone who has frequent low sugars or you're on medication that can cause low sugars, that you speak with your doctor about maybe getting a glucagon emergency kit and teaching someone in your family or someone that you're with throughout the day on how to use this. Hyperglycemia, depending on how high it is, if your levels are 200 to 300, you want to drink plenty of water. Your doctor may actually prescribe a rapid acting insulin, which I'll talk to you about later, to correct the high sugar. And if your sugars are very elevated, it's important to check at least every 4 hours and to keep your doctor informed should any other therapy be needed, or if it's really high, if you need to go to the emergency room. So now I'm going to talk to you about diet and lifestyle. So with diet, specifically our dietitians and diabetes educators at Rush are great resources for patients with diabetes. They can help tailor the diet according to your food preferences. I will tell you, following a healthy diet is just as important as taking your medication to effectively control your blood sugars. So you can break down diet into 3 groups, essentially. So it includes protein, fat, and carbohydrates. Protein refers to things like meat or seafood or tofu. Fats refer to things like oils, nuts, and butters. And carbs basically refer to everything else. And it's actually the carbohydrates that we worry about the most with our diabetic patients. So carbs can indicate any of the following products. So that includes bread, rice, cereal, pasta, snacks like crackers, cookies, chips, and popcorn are all carbs. Starchy vegetables like potatoes, corn, and squash are all carbs. Dried beans and peas also contain carbs. Fruit, although it's really tasty, also has a lot of sugar in it, as well as fruit juice, so you have to be careful with that. Milk and yogurt also contain carbs, as well as sweets. So carbs are not necessarily the enemy, it's more about moderation, and that's something that the dietitian can help you figure out upon consultation. So in general, to give you a brief idea, the goals for carbs per meal really depends on the patient's weight objective. So in men, if they're trying to lose weight, they should not consume more than 45 to 60 grams of carbs per meal. If they're trying to maintain weight, they should consume anywhere from 60 to 75 grams of carbs per meal. For women, if they're trying to lose weight, 30 to 45 grams of carbs is appropriate per meal. If they're trying to maintain weight, anywhere from 45 to 60 grams of carbs is appropriate. And so learning how to count carbs really is something that a dietitian can help you with. Also, a lot of the foods that we eat have nutrition facts on it, and you can easily locate the carb content on the labels. If you are going to have snacks during the day, it's recommended that you have anywhere from 0 to 30 grams of carbs per snack, again, depending on your weight goals. An easy way to kind of outline how to break up your food groups is to use the plate method. And so when you look at the plate method for diabetic patients, only a quarter of your plate should consist of the carbs, which include starchy foods. Only a quarter should consist of protein, and the rest could consist of something like non-starchy veggies, for instance. And so each patient will have their own tailored plate depending on their diet and their food choices. And that's something that the dietitian can help work with you on to determine. So just like diet is important for diabetes control, exercise is as well. So the goal is to get in about 150 minutes per week, which breaks down to about 30 minutes over the course of 5 days per week of activity in. And so I always say start slow and build your way up gradually. So everyone has varying schedules depending on work or your lifestyle. And so you could start up with something as simple as 5 minutes a day and gradually build your way up to 30 minutes a day. And if you've already been exercising, it's important to pick up the pace and intensity every 6 weeks. Our bodies do plateau after a while with given repeated activity. So especially if you're trying to lose weight, change up your routine every 6 weeks if you're able to. Independent of weight loss, activity does lower blood sugar levels. So if you do go for a half an hour walk, you'll notice that your sugars will be even up to 100 points lower than where you started. And so just like medication or diet, as you can see, activity is an important part of regulating your sugars. So a nice mnemonic to remember to keep track of diet and lifestyle is the SMART mnemonic. So S stands for specific, M for measurable, A for achievable, R for realistic, and T for time-based. And so for specific, this would refer to food choices or your exercise routines. For measurable, this could refer to your food choices in terms of the amount of food you're going to eat. Achievable is basically taking one day at a time, taking one thing at a time with regards to your diabetes control. Realistic, refers to just building up gradually to your target. And that could be for your diet or for your exercise. And then following a time-based routine could apply for both setting aside time to meal prep maybe for the week, or just setting aside time to exercise. So now I'm going to talk to you about diabetes medication. And first I'm going to focus in on the oral and non-insulin injectables that are out there for type 2 diabetics. So these medications can target different organ systems of the body to help lower sugar overall in our type 2 diabetic patients. So it can start at the level of the brain, where it will help you increase your sense of satiety or fullness. It can also work at the level of the pancreas, where it blocks the breakdown of a hormone known as GLP-1. GLP-1 is important for appetite suppression, weight loss, and insulin production. Other medications can work at the level of the muscle to make them more sensitive to insulin that your body's producing. Others can work at the level of the liver to inhibit it from producing too much sugar. Other medications can actually tell your pancreas to release more insulin on their own. And a newer class of medication can actually tell your body to get rid of the sugar through the urine. And so I'm going to break down the medications by class. So the first class, which is our first line treatment choice, is a biguanide known as metformin. Metformin works by helping the liver reduce the amount of sugar that it produces and releases. And it also makes the body more sensitive to using the insulin your body's producing. So there's been a lot of press lately on metformin, specifically metformin extended release. And so I'll tell you, there were several manufacturers involved with the FDA recall that's out there, but it does not affect the regular metformin. And it also does not affect all the variations of extended release that's out there. So my advice to you, if you are on metformin at home, specifically extended release, is that you should speak to the pharmacist to see if your particular batch was involved in the recall. And if it is, definitely talk with your primary care doctor or your endocrinologist to switch you to a different medication. Another class that we use in our type 2 diabetics are sulfonylureas. So the common two that we use include glimepiride and glipizide. Glyburide is an older agent. I personally don't prescribe this simply because it's not as safe as the other two. It's more likely to cause low sugars, and it's actually been found to increase your cardiovascular risk. And so if you are on this medication, I'd encourage you to talk to your primary care doctor or your endocrinologist about switching you to the safer two agents that are in the class, which include either glimepiride or glipizide. So basically, this medication works to help the pancreas release more insulin into the body to bring down sugars. TZDs, which is known as Actose, basically improves your body's ability to use insulin. DPP-4 inhibitors include things like Onglyza, Januvia, and Tradjenta, and this basically works to prevent breakdown of the hormone GLP-1, which in turn helps with appetite suppression and promoting insulin release. SGLT2 inhibitors, which you're probably seeing more commercials for lately, include things like Farxiga, Invokana, and Jardiance, and this helps increase sugar excretion through the urine. This particular class is favorable for type 2 diabetics because there have been multiple studies that show that these agents can help reduce your risk of heart attacks and strokes over time. And so oftentimes we'll reach for this class of medication if possible for our patients. GLP-1 receptor agonists include things like Bydureon, Byetta, Trulicity, Victoza, and Ozempic. Ozempic has been on TV a lot lately, and I would say it's probably one of the most effective ones in this class simply because it causes a lot of weight loss for our more obese type 2 diabetic patients. So the way this class of medication works is that it helps increase insulin release, suppress appetite, and promote weight loss over time. Like the SGLT2 inhibitors, this also has a protective benefit against heart attacks and strokes over time. So now I'm going to move into the insulin-based diabetes medications out there. So first, I'm going to talk about basal insulin, which refers to long-acting insulin. And so this can be used in type 1 or type 2 diabetic patients. And this basically treats glucose produced naturally by the body without food. So even if you're not eating, you should be taking this insulin every day. And depending on the type you're on, this can be dosed either once or twice a day. And so the common ones I've listed here, that includes things like Detamir, also known as Levemir, or Glargine, which is known as Lantus, or Basaglar. Toujeo is also a form of Glargine that's more concentrated. Degludec is a newer one that's come out, I think it's been over 5 years now, known as Tresiba. And then NPH has been around for a long time, and this is the one that would be dosed twice a day. The other type of insulin that's available are the short-acting insulins, and these short-acting insulins are basically used to treat mealtime-related sugar highs. And so if you're not going to eat food or you're going to skip a meal, this is the type of insulin you hold. So the names of these insulins include things like Lispro, also known as Humalog or Admelog, Aspart, known as Novolog, Fluoxetine, known as Apidra, and then regular insulin, which has been around for a long time. The other option for using this medication outside of just food consumption is if you're experiencing high sugars for other reasons. So this could be from infections or being on steroids. So sometimes doctors will temporarily prescribe this insulin to bring the sugar readings down in those situations. There's also a third category of insulin known as the premixed insulins. And these premixed insulins contain the NPH insulin, which is the long-acting insulin, along with a short-acting insulin known as Humalog, Novolog, or regular insulin. And so being premixed, this insulin is actually dosed only twice a day. However, it's not safe in patients who are not eating 3 regular meals a day because it can actually lead to low blood sugars. But if you are worried about whether or not you can keep up with multiple injections a day, this may be a good alternative to taking 2 separated insulins. So there's different ways you can get insulin into your body now through injections. So the first is through an insulin pen. Another method is through the traditional insulin syringe and vial. And the third method is through insulin pumps. And so insulin pumps are something that we use often with our type 1s, but I also use this in my type 2s who are completely insulin dependent. So the key thing to remember about diabetes medication is that these medications don't work if you don't take them. So it's important that these medications be taken regularly and appropriate. Your doctor will indicate to you what time of the day to take these medications, especially if they're medications you take with food. If you are having problems remembering to take your medications, definitely think about pill boxes or speak with your doctor or diabetes care team on other ways to keep track of your medications. But if you ever have questions about what to take and when to take them, don't guess, always ask your doctor. So now I'm going to talk about diabetes complications. So a common complication in our diabetics is diabetic eye disease, known as diabetic retinopathy. And this is due to sugar damaging the blood vessels in the eyes. So it's important that you get a dilated eye exam once a year to screen for this. If you notice that you're having issues with your vision or new dark spots in your vision, or you just can't see clearly in dim light, or if you're having any eye discomfort, definitely see your eye doctor sooner. But this is really key and should be done once a year. The diabetic foot is something we worry about with a lot of our patients, and specifically I'm referring to things like diabetic neuropathy, where you can't feel certain sensations, or just poor circulation in the feet. And so it's important that once a year that your doctor checks 2 tests on your feet. One includes the monofilament test, and the other includes the tuning fork test. I'll talk about that in the next slide. If you do have a history of poor circulation or diabetic neuropathy that is known, it's important that you see the podiatrist regularly for routine exams. And then there's also things you can do at home to protect yourself against getting cuts or ulcers on your feet, and I'll go into that in a couple of slides. So in this slide, basically on the left, you can see what the monofilament test looks like. And so essentially with the monofilament test, there's different points on the bottom of the feet, as well as on the top of the foot that we're checking to see if you can feel light sensation. On the right, you can see the tuning fork test. This is basically to see if you can feel the sensation of vibration. And so oftentimes your primary care doctor or your endocrinologist will check this on you at least once a year to make sure that your sense of sensation is intact in the feet. So on a personal note at home, you're able to do a number of things to help avoid complications with diabetic feet, as well as prevent any ulcers or cuts from happening. So it's important that you check your feet every day, and you can inspect that after you get out of the shower using a mirror if you're not able to see it clearly, just looking directly at the feet. It's important that you wash your feet in lukewarm water, but not hot water. Hot water will dry out the skin and lead to increased risk of cuts. Definitely moisturize your feet throughout the day if possible if you have a lot of dry skin. As I mentioned earlier, dry skin can lead to cuts or even ulcers over time. It's important that you groom your nails carefully. If you're not able to see well, it's important that you have someone else do this. That way you know that your skin is not going to get inadvertently cut through the nail clipper. If you do have an ulcer or a callus, do not treat it yourself. Please see a foot doctor right away, or let your doctor, your primary care doctor know. When you're going to put on your shoes, make sure you shake them out just to make sure that you get out any debris that could increase your risk of getting the cut on the bottom of your foot. Never walk barefoot around the house or outside of the house. You just never know. If you do have neuropathy, you may not be able to detect if you stepped on something sharp. And as we've talked about throughout this lecture, it's really important that you take care of your diabetes. So good sugar control is key to prevent complications like diabetic neuropathy over time. And then getting your annual foot exam is key from your doctor. So other complications we worry about are related to diabetic kidney disease. So we'll oftentimes check a urine protein screen once a year, along with a kidney function test. Urine protein leakage into the urine is actually one of the first signs of kidney damage from diabetes. And so the measurement we're looking at is something known as a microalbumin, and that's specific for our diabetic patients. Other complications we worry about include heart disease or strokes over time. So ways that you can modify your risk for this outside of sugar control is to follow a low sodium diet, increase your intake of fiber through fruit and veggies, reduce your intake of saturated fats like bacon, butter, sausage, eliminate any trans fats in your diet. And it's important to be active where you get good cardiovascular activity through exercise. And if you are a smoker, it's definitely important to quit smoking altogether. Diabetics are also at risk for gum disease. So for this reason, it's important that you see your dentist at least twice a year and definitely let them know you have diabetes. One thing you can do at home is just brush and floss your teeth regularly. And then from a sexual health perspective, high sugars over time can lead to erectile dysfunction in men, and women are more likely to experience vaginal dryness if they have diabetes. So now I'm going to go into just living with diabetes day to day, especially in the year 2020. So with COVID-19, a good resource for all patients is really the American Diabetes Association. I've included the link in my slide, which basically goes through all the frequently asked questions related to COVID-19. But to highlight the key points here, patients with diabetes are not at increased risk of contracting the infection when compared to the general population, but they are at risk for severe complications from COVID-19 when they are infected. So it's important that you pay attention for any potential COVID-19 symptoms. Unfortunately, now with flu season upon us, it's oftentimes hard to distinguish whether it's COVID-19 versus the basic flu. But either way, you should let your doctor know if you're experiencing things like fever, dry cough, shortness of breath, chills, muscle aches, headache, sore throat, or if you have a new loss of taste or smell. The Rush website actually has a hotline that you can call 24/7 if you have any worrisome symptoms. And I've included the number here in my slide. And if you need this phone number, I think Jasmine hopefully can provide that for you. So in terms of just precautions, you want to follow the same precautions as the general population to protect yourself from contracting COVID-19. Always wear a mask, but the key part is you need to cover your nose and your mouth, not just one or the other. Keep a 6-foot distance from others. Even asymptomatic people can spread the virus. Definitely wash your hands regularly and for at least 20 seconds. You want to get hand sanitizer that contains at least 60% alcohol. Anything less than that won't be sufficient to kill the virus. And definitely make it a point to clean and disinfect frequently used surfaces in the home. So with other routine things in terms of being diabetic, when you are driving and you are on a medication that's known to cause low blood sugar, it's important to check your sugars before driving. It's also important to carry a quick-acting glucose source in your car if you do develop a low blood sugar while on the road. If you are traveling out of state, definitely bring extra medication and testing supplies. Carry on all medications and your blood sugar meter on your flights. And it's also important to bring original prescriptions for your medications in case you run out or you need to get a new stash at the location you're traveling to. It's important to check your blood sugar often and plan for meals and snacks, so that way you can check up on any potential low blood sugars. And if you are insulin dependent, it's really important that you wear a medical alert bracelet indicating that you have insulin dependent diabetes. This way, if you do happen to pass out and no one you know is with you, at least the paramedics will know that you have this history and will check your sugar and treat it if it is low. On an emotional level, diabetes and living with diabetes can definitely be trying, and I've seen a number of diabetics that are suffering from depression. And so when you have depression, it's very hard to take care of yourself and you're less likely to take your medications or to eat well. But if you happen to know that you are showing signs of depression, such as loss of pleasure, change in sleep patterns, change in appetite, loss of energy, morning sadness, or any suicidal thoughts, definitely let your doctor know right away. You could always talk with your physician or a health psychologist if needed. And oftentimes that in itself can help patients get through this depression. We have a number of good resources for patients on this level. So within the Rush Behavioral Health Department, Dr. Mackenzie Kelly is a great resource for our diabetic patients. She's a health psychologist that works closely with our diabetics. Rush Generations itself offers a Rush Diabetes Support and Education Group, and there's various online resources through the American Diabetes Association the American Heart Association, and through the National Diabetes Information Clearinghouse. So that is it for my talk. And now I'm open for any questions that you might have.
Thank you so much. Thank you so much for that lecture. And I also loved seeing the parallel between what we heard before the pointer study and all those wonderful things we can do for our health and how that's also in line with what you shared. So thank you so much. We do have a few questions already. And so before I read the ones we had online, I just want to open it up first to the people who have joined in over the phone. If you have any questions, you can unmute yourself now and ask your question. All right, so we'll go ahead and get started with the questions we have online. And again, for those of you who have joined online, any additional questions, you can go ahead and add them to the chat box. The first question we have is, if I am pre-diabetic, what should I do to prevent diabetes?
Great question. So the key part is to intervene with lifestyle right away. So that includes changing up your diet if it happens to have a lot of carbs in it, following a healthy lifestyle with regards to activity. So if you are able to move and you don't have any ailments that prevent you from exercising, both following a healthy diet and being active are key to prevent progression to type 2 diabetes. I'll tell you, if patients have a strong family history of type 2, sometimes despite those measures, you may still end up developing it, but at least you'll have a more controlled state if that does happen to you.
Why does it matter if my blood sugar is high or low?
Great question. So if it's high, we worry about those complications that I went through. So prolonged high blood sugars, where your A1C actually ends up averaging to be above your target, whether that's 6.5, 7, or even 8, means that you're at risk for complications like eye disease, kidney disease, losing sensation in your feet. On a bigger scale, you worry about things like heart attacks and strokes, or even amputations over time. And so that's the reason why we worry about the high sugars in a prolonged period of time. The low blood sugars are also dangerous, and that's even more acutely dangerous because if you have a low sugar and you don't treat it, you can actually pass out or even die from a low sugar.
All right. Is it okay to share a glucose meter with family?
Yeah, I get this a lot, and it's not. The reason why I say that is because if your doctor is looking at your glucose meter firsthand in the appointment, he or she can get confused by the data they're looking at. They don't know if they're looking at your sugars or someone else's sugars. I've seen this a lot in my practice, and I strongly discourage it. You know, that Rely On meter that I told you about at Walmart is pretty cheap compared to other meters that are out there. And so I'd encourage whoever is in your family to get his or her own meter.
And thank you so much for sharing their resource too. I know we've heard how difficult it can be and how expensive it can be also.
Yes, yes.
Are there side effects to injecting this? There's two parts to this question.
Sure.
Are there side effects to injecting insulin, and is it dangerous to miss an insulin shot?
Both great questions. So the main danger you worry about injecting insulin if you're not on the right dose is that you can either get too high of a blood sugar as a result or too low. So I would say of the two, the most dangerous one is the really low blood sugar. So let's say you're prescribed a higher dose than you really need. Your sugars can drop pretty quickly after taking the insulin. And so it's important that if you do have a history of insulin-dependent diabetes, that you have those quick-acting sugars near you, like glucose tablets, or if you're at home, you have some juice that's accessible to you. But that's a common danger that is associated with insulin use. A common side effect I'll tell you of using insulin is some weight gain. And this is why following a good diet and being active is really important to help curb the effect of that. From a type 1 diabetic perspective, the high sugars can be just as dangerous as the low sugars. So there's a diabetic emergency that can happen if patients are not getting their insulin properly or they're not taking enough, where if the sugars are high for a long period of time, they can actually become nauseous, have stomach pain, and their blood can become very acidic. And so that could be actually a life-threatening emergency if that's not treated. And so we see that mostly in our type 1s who may miss doses of insulin, or they're just not taking enough to cover their food, for instance.
And then, can you explain an A1C?
Yeah, so the A1C basically tells you how sugar-coated your blood cells are. And so our blood cells normally turn over in our bodies every 3 months, and that's through the action of our spleens. But the A1C is a nice 3-month average of your sugar control. So I'll tell you, it's a guide for your doctors. It's not the specific target we look at when we're trying to adjust your medication. What's more important is actually the day-to-day sugar changes that we're seeing throughout the day to make changes to your meds. But at least if you see that your A1C indicates that your 3-month average of sugar control has been good, at least you know you're on track to help reduce those risks of complications that I discussed earlier.
Okay, we got a couple more questions that just came in.
Yeah.
How does metformin and glipizide work together?
Yeah, so they both are medications we use in our type 2 diabetics with the end objective of lowering sugars, but they target different things. So metformin actually tells your body to become more sensitive to the insulin that it's producing on its own. And as a result, it's able to lower the sugars quicker through that means. Metformin also decreases how much sugar is put out by your liver by itself, which is also another effect of that medication. Glipizide or glimepiride or the sulfonylurea class I was mentioning tells your body to produce more insulin. And so if you were to take the 2 medications together, basically you have one medication telling your body to produce more insulin, and then you have another medication telling your body to use that produced insulin in a more effective manner with the net goal of lowering the sugars.
That's a good explanation. And then we have just a comment here that said, having a food journal will help for pre-diabetes.
Yes, agreed. And so actually, if you bring that food journal, if you happen to have a dietitian appointment, that's really important because then your dietitian can actually point out to you, this is a good food choice, this isn't a good food choice, but I agree, keeping a log definitely helps.
And then the second to last question we have, I hear positive and negative things about the very low carb or keto diets for diabetics. Please explain problems with this type of eating plan. Thanks.
Yeah, that's a wonderful question, and I get that asked often to myself by my patients. So the keto diet, I will tell you, is effective when it comes to weight loss. When your body goes into ketosis, it's basically using fat stores as a way to give your body nutrition. It's actually not our primary source of fuel, it's more of a secondary source of fuel. But if you do go on a keto diet, you'll find that you're going to lose and burn fat very quickly. My issue with the keto diet is that it's not sustainable. And specifically, especially for our type 2 diabetics, who oftentimes struggle with diet, not all of them, but some do. You know, being so restrictive in how much carbs you can eat can actually be very detrimental over time, I think, for your mental health, where you may feel like you can't eat certain things, and that could potentially put you into a more anxious state. So I'm someone who prescribes moderation, where you should do a low carb diet, but something more moderate where you can see yourself continuing this for months or years to come. Keto diet, I've seen patients do it. They fall off of it. They eat a lot of carbs and then they gain the weight back and more. I definitely recommend against this diet completely in type 1 diabetics because of that diabetic emergency that I mentioned earlier. Those patients, if they were to go on a keto diet, can actually put themselves at risk for that diabetic ketoacidosis emergency. So keto diet is all of the rage right now, I should say, as well as intermittent fasting. But I am not a fan of either of those diets, especially in our diabetic population.
Thank you for mentioning the socio-emotional part of that as well. We've heard that from participants too, that it can be so difficult when you're having family dinner or like coming together with dinner and then your plate looks so different from that of others. So thank you for bringing up that point. All right, and then the last question is, how can I get connected to a diabetes educator at Rush?
Yeah, so there's a couple of ways. So if you have an endocrinologist, we actually have our own diabetes education team, and we have about 3 over at Rush right now. If you're seeing a primary care doctor for your diabetes, there's plenty of nutritionists and dietitians at Rush that your primary care doctor could get you plugged in with. So you just need to ask him or her about it, and they can put in a referral for you.
Great. And then we have some people just saying thank you. So thank you so much.
You're welcome.
Those are all of our questions. Thank you so much, Dr. Zachariah, for making the time and for answering all these questions. And to the participants, we're going to go ahead. Oh, actually, before we end, I see that there's 2 more people on the phone. Did any of you have any questions? Did either of you want to unmute yourself? And you can ask your question to Dr. Zachariah. All right, we're good to go. Thank you.
You're welcome.
And so for those of you who are online, I'm about to show you a screen. And for those of you who are over the phone, I'm just going to share a few of the programs that we have coming up with Rush Generations. So as you know, over the past several months, we've been able to shift a lot of our programs virtually. And I know a few of you have asked me, what is virtual? What does that even mean? And really what that means is that instead of going in person, we have options to join over the phone or on the computer so that you can join safely from your home. And so we have a ton of great programs, including our workshops, fitness classes, lectures like this one, support groups that are all moved virtually. So you can join over the phone or online. And so I'm going to go over just a few of them. Don't worry if you don't remember any of the details, because I will give you our main number at the end. And so you can call and tell us about your interest and we can help get you started. Also, if you're not comfortable using the computer or would need some assistance to really learn how, we're here to help. So as long as you're interested, we're very happy to help you and guide you through the technology side of things. So first, we have the Take Charge of Your Health workshop, and that will be coming up on November 24th, and that'll be from November 24th through December 29th on Tuesdays from 1 to 2 p.m. The Take Charge of Your Health workshop is a workshop where we learn how to better manage our chronic conditions. So learning about some of the things we talked about today, eating better, having a more active lifestyle, creating an action plan, and making goals. And so that's a great opportunity. Another, we have our 2 fitness classes coming up for the virtual Zumba Gold from January 18th till March 8th from 1:30 to 2:30. We also have the virtual gentle chair yoga class. This will also be done virtually from January 21st to March 11th from 1 to 2 p.m. Now, both of these classes, each one costs $40 for the 8-week sessions. But of course, if that's too much for you, we can definitely give a scholarship if you're interested in joining. Next, we have a couple of support groups. We have the Coping and Connection in the Time of COVID support group. So this is led by one of our social workers where you can talk about the feelings and experiences at this time. And so this takes place the 3rd Wednesday of every month, so once a month from 3 to 4 p.m. Now, if you're interested, I can give you the number for the actual to join the group. You would call 312-535-8110 with the access code of 928-919-117. And again, you don't need to remember all these details. You can always call Rush Generations and we'll help get you signed up and give the information. The other support group we have is the Diabetes Education and Support Group. So this will be the 3rd Thursday of every month, again, once a month from 2 to 3 p.m. And so we have the access code for that, which is 312-535-8110 with the code that's 625-802-403. So again, that is the Coping and Connection, the Time of COVID support group. And we also have the Diabetes Education and Support Group. Next, we are recruiting for community health mentors. I know a ton of Rush Generations members have been community health mentors in the past. And so for those of you who are interested, or for those who may have been hearing about this for the first time, being a community health mentor means that you're paired with a group of students at Rush. So this is a mix of students. These could be medical students, nursing students, students that are learning about health administration, speech language pathology, a big mix. And the goal is for you to be a mentor for them. So for them to be able to learn from you about what it's like to live with a chronic condition and what the challenges are and what your community is like. And in turn, they're also going to help you to create a goal and to meet your goal. So it's a wonderful opportunity. Typically, people have very positive reactions from this and find it very beneficial. And so this year, this will be done completely virtually for the first time. And so if you're interested in signing up for this, you can also call the Rush Generations toll-free number. And the last thing I want to mention is Shaman Senior Voices. So the Shaman Senior Voices program is all about learning what matters most to you as you age. And especially at this time during this election, and of course before and after the election too, we want to learn what matters most to you. And especially at this time, it seems like a really ripe time to ask the question, what matters most to you as you age in America? And so we encourage you to explore Shaman Senior Voices, and especially to record your own video telling us what matters most to you as you age in the United States. And so you can record a video very easily in just 60 seconds by going to aging.rush.edu/shaman, SCHAALMAN. And once you go to this website, you can learn more about our initiative, and you can record a video in just 60 seconds telling us what matters most to you. And what we do with those videos is we learn from you about your perspectives and your experiences. And then we take that to educate healthcare students, to have conversations with providers, to create programs, and to have larger conversations on aging. So we really encourage you to make a video. And if you have more questions about it, if you're not feeling too safe about it, or if you just want to learn how to do it, please do give me a call. I'm happy to share more about this project, and also happy to guide you with instructions on how to do it. So I'm happy to walk you through recording a video. We really would love to learn from you and your perspectives. And so you can reach me by calling 312-942-6995. Or you can email me at Jasmine, JASMINE _Chandy, CHANDY @rush.edu. And just one final reminder that Rush Generations is with you during social distancing. Again, we have tons of great programs that we didn't even mention all of them just now. So if you're interested in learning more about our programs or would like to get involved, you can call our toll-free number at 800-757-0202. And also, if you'd like to sign up for our e-newsletter to receive an email on our upcoming programs, you can sign up by going to bit.ly/rushgenerations. And the R and the G in Rush Generations will be capital. So that's bit.ly/rushgenerations. Thank you all so much for joining. We really appreciate it. And if you'd like a copy of the slides, or if you'd like to be connected to anything, please do give us a call and we can definitely do that for you. Take care, and thank you.